Thank you. Let's first start doing a little exercise. And before we do this, I want to preface this. Remember, I deal with the darkest part of mental health, of course, suicide, homicide, et cetera, et cetera. So at any point in time, some of the stuff might get a little heavy. And if at any point in time, truly, it incites feelings within, it kind of tugs on those, strings by the heart, then go ahead and step out, of course, and just let your neighbor know that it's okay, or rather that you're okay. Because truly, believe it or not, even the most trained professional, even going through just a simple hour of this type of stuff, can affect the person quite a bit. Okay? So first, let's do this exercise, and again, this is voluntary, of course. Let's do an exercise. Everybody close your eyes. Now, loss. Think of loss. The word loss, over and over again. Picture the word, picture the letters. Think of the thoughts that come to mind when you see the word, when you see the letters. Now think of that in your life. Think of the greatest loss that you can have. It does not have to be a family member or a loved one, simply a loss. Whatever you hold value, you hold great significance to that. And now the word loss comes to your mind, to your psyche. What thoughts, feelings, reactions come to your mind? What behaviors will you exhibit? How will others react to this loss around you? Okay, let's go ahead and stop. Everybody open your eyes. Who had some thoughts of sadness? It typically should be everyone, right? All right. Who had, no, I'm not using the word suicide. Who thought of death? Okay? Majority of people, loss is going to be associated with loss of a loved one. Okay? Who thought of suicide? Not saying your own, who thought of suicide? One person, thank you. Who thought of your own suicide? Nobody's brave enough. But bottom line is, there always is, rather those thoughts are always going to be in your mind when there's great loss. Okay? And it's not to identify people in here that may think of suicide, no, but it's a matter of, the point is, everyone is vulnerable to suicide. Everyone. Okay? And the main reason that suicide does occur is loss. Now, suicide is more of a idiosyncratic type of event, meaning it's not one singular event that actually causes a person to kill themselves. It's a culmination of events, many, many life stressors, years and years of stressors perhaps, history of mental illness perhaps untreated, unsuccessfully treated, maybe a lot of comorbid mental health diagnoses, a lot of medical issues. Again, a culmination of events. But then perhaps there was a trigger. Not always, but sometimes there's a trigger that actually leads that person finally to the edge and then into suicide. Okay. First, I'm going to describe the department that we have, which is the Intake and Crisis Emergency Department that Alfonso was describing. And we're going to put some of these out back, and that way you can actually see what the department does as well. Do you mind? And I'm going to show you a video as well. It's a very brief video, and then we'll jump into the actual presentation.
Welcome to Paso MHMR. Our team of professionals is here to help you and your loved ones through the client intake process and guide you to the services you need to facilitate your recovery. Our center serves 6,000 individuals with mental illness and mental
I'm not a nurse or a doctor. I didn't have one that day, so okay, sorry.
Our professionals are available 24 hours a day, 365 days a year. After speaking to our mental health experts, they will work with you and your family to determine your treatment plan. Individuals in crises
Until
have
12:30,
several
that's it, right?
options to receive treatment. For those
Are we getting
in
lunch here or
immediate
not?
and severe crises,
Really?
hospitalization
Okay.
options are available. For those with less acute symptoms, our crisis
hot chicks?
stabilization service
Have you
allows
identified them?
individuals
Have
to
you identified
recover
them?
in a controlled and
There's
safe
one in the back right there in
environment.
black.
And
Second to the last
finally,
row,
there
this
is
side.
an array of
Second to the last
outpatient
row.
services
This
for
side, this side.
individuals to continue treatment and recovery. Our team will review all of these options with you and your family. The resources of our center are available to all El Pasoans. In our role as the Mental Health Authority of El Paso County, our mission is to ensure access to quality services, advocating for a better quality of life, and
I'll go into
providing
crisis and
strength,
suicide.
hope,
Yeah.
and recovery for persons with mental illness and developmental disabilities. We offer a variety of services to help our community access mental health resources. Our 24-hour crises hotline number, 779-1800, allows round-the-clock access to mental health professionals for anyone undergoing a crisis. The crisis professionals
fucking
who
keep it.
answer
Gary-
the
Gary
phone
doesn't even
will
know. Fuck it,
assist
dude.
you with a
I mean,
variety of
seriously,
mental
fuck
health
it.
needs. Our walk-in crisis service allows you to speak face-to-face with one of our trained professionals anytime, day or night, at our 1600 Montana location. The Mobile Crisis Unit is a mental health center on wheels designed to provide comprehensive mental health services at remote locations around the region. This vehicle is equipped with satellite uplinks to allow interaction with psychiatrists and other mental health professionals to outreach to people in crises from locations across the globe. El Paso MHMR maintains 19 outpatient facilities in El Paso that offer specialized services to adults, children, and
I don't know why there's an ocean
adolescents.
there.
In addition, El Paso MHMR works with a network of private providers offering quality alternatives. Or you can simply log on to www.epmhmr.org to learn more about our services and access the latest information about mental health and mental illness.
Okay. So we'll go ahead and begin now. Now, first off, let's define what a crisis is. Somebody, anybody. What is a crisis? Think of your loved one, think of yourself, think of things in the past. What is a crisis? It's an emergency. Yeah? Okay, any dire emergency. Here's the actual definition of it. It actually puts a little bit more light and a little bit more insight on it. A person's inability to cope with a given situation. A person's inability to cope with a situation. Meaning, you can have two diverse persons. One with great coping skills that have been perhaps developed throughout life. Another person, maybe not so great coping skills. They both deal with loss. One can cope with the loss better, perhaps, still grieve, of course, still go through the process, but not necessarily in full-blown crisis. Well, the other person that has not developed those great coping skills, mechanisms to deal with life stressors, is not going to deal with that crisis. So, and hence, go into crisis. Okay, make sense? Okay. Now, first, crisis also overlaps a lot with suicide. Crisis management can be really described as, you all see that? Not really? Not well? Okay. There's crisis prevention. So preventing from a crisis from even beginning with any person, any patient, anybody really. And we'll go through some of those techniques very briefly. We only do have 45 minutes, of course. This usually takes a whole week, but that's okay. I'm going to go through it very quickly. There's crisis intervention. Things called safety contracts that we don't do anymore because now we call them crisis safety plans because of the legal ramifications and the fact that safety contracts don't really work. Okay? Anyhow. Crisis resolution. Crisis resolution, do we hospitalize a person? Do we not hospitalize a person? If we don't hospitalize a person, what type of aftercare is there? It's not simply dropping off the patient and handing it off. It's simply ensuring that that person you're handing off the person to is actually providing the service that you requested. So in other words, following up on the person for aftercare. All right? So again, that's follow-up. And of course, there's also assessing, risk assessment. Right? So first, let's go over the social theories of suicide. Altruistic suicide, first off, the most uncommon. Okay? A person kills themselves hence to die by the sword. Okay? The betterment of society. I'm going to kill myself so my family can benefit. I'm going to kill myself so perhaps society can gain from it. Okay, that's an altruistic suicide. The most common ones is going to be egoistic and the anomic. The fatalistic. Okay, so meaning that they're escaping something due to avoidance. They're escaping either oppressive conditions, whether it's a household, a country, something. They're escaping something. Then there's the one, of course, the egoistic. Okay, lack of connection to society. So they feel unconnected. They feel depressed, anxious, etc. Okay? And it's important to identify what types of suicides we're dealing with, and that way the intervention can also be the same. It can be tailored to the individual. Okay? Crisis management can also be described as not having black and white, it's really always functioning in the gray. Always functioning in the gray. Because every individual is different. And every individual reacts differently to the stimuli, to their environment, to the stress. Every individual, sure, you have 3 individuals with depression. But you may have one person with depression with mild depression, with mild symptomology that has been treated successfully throughout his entire life, where another person perhaps there was a late onset. So again, you have varying degrees of individuals. Thus, the tailored crisis intervention is going to be just the same, tailored to the individual. So hence again, functioning in the gray. All right. Now first let's talk about, within suicide, we have risk factors and protective factors. Protective factors can also be called risk reducers. All right. Now, whenever we do risk assessment, whenever we assess anyone, whenever we're thinking of a loved one that might be perhaps at risk for suicide, it's important to note those risk factors and those protective factors. Because if there's an abundance of risk factors, well, the person may actually, again, the perpetuation for suicide might be there. All right. Now, it doesn't mean that the person has an abundance of risk factors and absolutely no protective factors. The person will kill themselves, guaranteed 100%. Of course not. Again, it's human behavior. I always say this a whole lot. We cannot predict human behavior to the T. We, of course, strive for it, but we're never going to get there. Never. One of the risk factors is geography. Does where you live put you more at risk for suicide? Yeah? Okay. So, thoughts. If we look at the globe of the world, what countries, industrialized countries, have the highest rates of suicide? The most prevalence? Japan. How did you know that? Who said that? How did you know that? Excellent. And I had a little hint earlier, to die by the sword, right? So, meaning what? There's kind of a social, cultural acceptance to suicide. In China and Japan, both countries have the highest suicide among industrialized countries. However, in the last 10 to 15 years, there's been a lot of more awareness campaigns and actually intervention campaigns to actually, again, curb suicide in those countries. As far as non-industrialized countries, Lithuania and the Ukraine have the highest rates of suicide, typically because of oppressive conditions, socioeconomic status, et cetera, et cetera. Many other reasons that perhaps Japan and China are not the reason. That's why, again, suicide is very multifactorial. It's not simply, oh, well, I was depressed, or I was this, or this person lost this. It's typically a culmination of events mixed with environment, biology, psychology, many, many things. And if we look a map of the U.S., what do you all believe? Which region of the country has the highest rates of suicide? Seattle. And everybody thinks it's the Pacific Northwest. Because of why? Because of what? Because of the weather. That is one factor, yes. And you're correct to a point. Right? It is weather related. But there's one specific reason, and it's called geographic isolation. Okay? The states in red have the most sparse populations. Right? New Mexico being number 4, by the way, in the whole country. Montana being number 1. Along with Alaska, number 2, number 1. They kind of go back and forth. Anyhow, think of the movie The Road. Everybody see the movie The Road? No, great. Yeah, it's one of those that didn't do well. It's just actually a very recent movie too. It's basically this father. It's a post-apocalyptic movie, end of the world, and this father is trekking along with his son. He's about 7 years old, roughly, Oh, you guys saw it. Okay, you guys didn't like it. Okay, anyway, I liked it. Anyhow, and he's trekking along, and the son, the entire movie is basically him trying to strive to be with another human being, other than his father. So finding that human connection is really key. Not necessarily romantic, but simply having a human connection. When you live in Wyoming, that's Wyoming, right? Yeah, it's Wyoming. It may take you 2 hours to get to that friend that you have, hence that primary support system. That's a protective factor, by the way, a primary support system. Sure, you can call that person over the phone, but sometimes, again, you need further human connection. It may take you 2 hours to get to an emergency room. It may take you 4 hours to get to a therapist. So again, hence geographic isolation, yes, weather, but also lack of resources. Okay? And if you live in these sparse areas, you are going to have lack of resources, or at least limited resources. Think of traveling between here and San Antonio. What is there? Nothing. Absolutely nothing. Stopped in so I apologize if somebody's from Fort Hancock or one of those places. But I stopped at a diner there. I really felt like just passing out some Prozac to these individuals because everybody just looked so down, you know. So the same goes with the state of Texas. The more rural you are, the more likely you are to complete suicide. The more rural you are, the more likely you complete suicide. The urban areas have actually the least of the suicide rates per capita. Per capita. Okay, it doesn't mean Abilene, Texas has more than El Paso. Of course not. It just means per capita. Okay. All right. Any questions up to this point with geography? All right. Another risk factor, age. Who completes suicide more often? The older you are, yes, the more likely to complete suicide. However, the second age group is your 15 to 24-year-olds. In Texas, it's actually like middle-aged. But if we look at the U.S., it is actually your 15 to 24-year-olds, your college-age students. And there's reasons for that. College-age students and elderly are highest at risk, but especially your elderly. Now, there's something called transition within this time frame. Transition, on the elderly, there's retirement. Transitioning from independent life to dependent, perhaps. Okay? Perhaps successful career to now, again, being dependent on something else. Right? Transition, 15, 24-year-old, from high school to college, within college, stress, academic stress, familial stress, peer stress, many, many things. The movie comes to play Jamie Foxx, the soloist. Oh, you all saw that? Okay. This is also the age of onset for mental illness. You're 15, 16 to about 29 is the average age of onset of all mental illnesses. Yes, there's some outliers, of course, but typically that's going to be the age of onset for most mental illnesses. Dependent on gender and the actual illness, it's going to be more comprised within that age group, but it is typically between, again, 16 and 29. Within that movie, I think he was a teenager, and he sees out the window a car on fire passing through. What was that? A hallucination. Okay? But he didn't identify it at that time as that. So again, that's really the age of onset as well. That's why your 15 to 24-year-olds are going to be the second highest at risk for suicide. Now, we know that males complete suicide much more often than females. Why is that? Method. Absolutely. Method. Males complete suicide by firearm, the most common. Male. It's going to get a little gruesome here in a minute, okay? Males complete suicide by firearm. The second most common for male is going to be hanging or suffocation. Okay? Surprisingly enough, if a female does complete suicide by firearm, it's actually to the heart most commonly. If it's a male, it's to the head. Interesting. Female, number one method for female for ending life is going to be overdose. Second is going to be cutting of wrists. If you can imagine, those two methods are not guaranteed ways of dying. Okay. Firearm, almost guaranteed of dying. Not necessarily. Okay. Ethnicity. Okay, why is that up there? Why do Caucasians kill themselves much more often in the U.S. Than any other ethnic group? Now, note, Native Americans are not up there. They are actually the absolute highest. But they're not up there because they're barely counted in any statistics, really. All right? They're actually comprised, I think, typically less than 1% of the U.S. population. So it's very difficult to count that. And it's also federal land, and a lot of those statistics are not shared, et cetera, et cetera. Yes, ma'am? Excellent. Awesome. That same primary support system that I talked about, that protective factor, traditionally and culturally and historically, Hispanic and Black are going to be more based on, again, family support. A lot of the data most recently shows a lot of these lines actually combining within each other, meaning eventually we're just going to have one line. But that's maybe way, way down the line. Anyhow, Caucasians are still completing suicide much, much more often, though, especially your males, again, male elderly. If we look at suicide by age in just specifically Texas, there are some differences. Like I said, middle-aged are completing suicide quite often in Texas. Again, followed by your elderly. And we talked about method. What about your 15 and 19-year-olds? Same method. I want you to look at, though, 1997, right around here. All right? Still hold steady. The white line is for all suicide. This bar here, the squares, is firearm. So your 15 to 19-year-olds are still ending life by suicide by a gun. Okay? Now the next age group, 10 to 14-year-olds. Same thing, firearm, 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 until about 1996, 1997. What happened during this period? Hopefully I don't have any Republicans in the room. Gun ban. Okay? A lot of gun control laws by Clinton. I also do the homicide part of the trainings for the center and the community in regards to mental health, of course. The same numbers actually dropped during that time for homicide. Around 1996, 97, homicide just drops. Okay, you decide. All right. Now, notice that I have been saying suicide completion quite a bit instead of committed suicide. Why do you all think that is? Completed suicide. Instead of committed suicide, successfully suicided, or what have you. Okay, sure. And there's also another term, suicide survivor. That's actually a misconception. A suicide survivor is not a person that attempts suicide and survives. No. A suicide survivor is actually a family member, friend, colleague that is left behind after a completed suicide. Now, I say completed suicide because most suicidologists, that's really the common term now. Committed suicide, it implies criminality. Back in the 1800s and prior to that, actually, suicide was criminalized in many countries, including this one, for a while at least. Ironically, people were actually put to death for attempting suicide. Not a joke, really. I mean, it really were. So that's why, again, not saying committed suicide. I know the media says that a lot and many other things, but again, it's completed suicide. All right? So as you can see there, definitions of a crisis. We talked about not the event. It is not the event. It may be the actual trigger. It may be that broke the camel's back, if you will. But again, it's not the definition of the crisis. A person's thoughts and feelings may be out of their control. There's a sudden deterioration in emotional or mental state. There's expression of suicidal thoughts or actions. Can a person kill themselves without expressing it? Absolutely. Now, let's talk about one question. Is it a myth or fact? A person kills themselves. A person will not kill themselves if they say it. Myth. Although, believe it or not, a lot of suicidologists actually do say if a person is truly intent on completing suicide, they're not going to really tell anybody. But why is that, you think? Because they're seeking help, in other words, right? But seeking help does not mean that, I'm seeking help, I'm not going to really go through with it. That means they're seeking help. It's a cry for help. They want help. Otherwise, they may not do it right then and there, perhaps, but they might do it later on. Okay? So. I'm going to jump over to some things. These are also symptoms of a mental health crisis, but also suicide warning signs. Now, before we jump into this, warning signs are a little difficult to define. A person may have multiple warning signs, meaning signs, symptoms within a person that actually, obviously, the person may lead to suicide, right? However, has anybody killed themselves without a single warning sign? Yeah, absolutely. Has a person killed themselves with ample warning signs, but nobody noticed them? Yes. Has somebody had multiple, many warning signs, many risk factors, and then killed themselves? Yes. So that's why I say it's very multifactorial, and it's very difficult to predict human behavior, including suicide. But yes, it is preventable. It is preventable. Sometimes we're missing the signs. But again, if the person at times is so intent on doing it, within themselves, they may not simply show a simple single sign, perhaps. But I don't want to say that because that seems fatalistic, that we can't help those individuals either. So again, it's a matter of just simply looking for those signs. So talks or plans of suicide are some of those symptoms and signs. Abuse of alcohol and or drugs, if perhaps they have not abused drug and alcohol in the past. And I'm going to look for a word within the next two slides that is kind of the revolving theme for warning signs and suicide warning signs, okay? So dramatic mood swings, staying awake, asleep for periods exceeding 24 hours, complete withdrawal from activities, others, bizarre behavior, whatever you want to consider bizarre behavior, uncontrollable anger, fits of rage, paranoia, suspiciousness. There's a change in affect. What is affect? Expression. Okay? And by the way, expression, body language is going to be key. Alfonso says that 70% of all communication is body language. I disagree with him. I say 93% of all communication is body language. He's our PMAB instructor. He's Preventative Management of Aggressive Behavior. In other words, he's the instructor whenever we have to restrain someone, how to do it correctly, et cetera, by state guidelines. So he's the instructor for that. But I rely big time on body language. Big time. I already know in here who's bored. I already know in here people in the back that are kind of doing other things like texting, things like that. Again, based on where your eyes are looking and things like that. So body language is really, really key. And the reason I say body language is key, only because you may be unknowingly conveying frustration, conveying impatience, but also at the same time, if you ask the person that might be at risk for suicide, hey, are you thinking about suicide? And if they tell you no, but their body language is telling you something different, they're looking down at the floor instead of looking at you in the eyes. They're fidgeting with their face, fidgeting with their hands. I mean, many things that convey anxiety, stress, perhaps, again, not being genuine with you. So body language is going to be key. Refuses treatment medications, impaired judgment and insight. If a person is in full-blown crisis or even the precipitating crisis, the insight is going to be off. The person's going to say, well, wait a minute, I can jump off this building and still survive, but I want to end up in the hospital because I'm really tired of all this. Well, okay, but you're jumping off a 5-story building. So again, the insight is completely off. I'm going to take 30 pills and fall asleep. I'm not going to kill myself. I'm going to take 30 pills and fall asleep. Again, insight and judgment is off because they're not thinking correctly. Yes, ma'am.
Is it too soon to ask, considering like if with these symptoms that you just described, is it when a person is truly in this type of crisis mode that they have to also murder their own families and then kill themselves? Does that have anything to do with this, or am I asking it too soon? Did we get to that slide yet?
I do the homicide part, like I said, as well. And really, the common theme there is that those that are mentally ill are no more likely to commit homicide. than a person without mental illness. Now, the theory there is that you're stating is, if a person is willing to kill themselves, do they care about someone else's life? It's going to be really individually based. There's no research on that. There's no statistics on that. There's no saying, oh, well, when a person is suicidal, yeah, they don't care about those around them. They're going to kill others. Not necessarily, no. I wouldn't say that. I would say it's going to be really just individually based. I think rarely do we hear about murder-suicides. We hear more about suicides, but again, the media does not report suicide, mostly. And we'll discuss at the very end on how media should be reporting suicide. These are other symptoms and also warning signs: mental health crisis and suicide. Just think about it. All these up here, what theme revolves around all of this? Change. Change. Change in mood. Change in behavior. Change in cognition. Change. Just simply change. We cannot pinpoint, oh, where a person's withdrawing from family members, I think he's at risk for suicide. Well, of course not. Change. Simple as that. Okay? As the parents, the siblings, colleagues, friends, they have to note, how severe is this change? How many other changes are there to note that suicide is imminent? So if we know that suicide is basically a concern, how do we approach this then? Do we ask about it? With the scenario I gave you all earlier, with closing your eyes, things like that, if you were at risk for suicide, what would you want someone else to help you with? How? Notice it? Okay, so identifying the signs and symptoms. And then what? So the person helping you, the helper, has identified all of that. What do you want that person to do next? Listen, okay, what else? Ask. Here's a rule. You ask clearly and directly. It's one of our regulations within suicide intervention. Ask clearly and directly. If I ask a self-mutilator, not related to suicide, self-mutilator, again, remember, cutters, cutting to relieve psychic pain, anxiety, etc., etc. There's no intention to die, just relieving pain, psychic pain, deflecting emotional, and anyhow. If I ask the person, do you plan to hurt yourself? The person's going to tell me yes, right? Because it's about self-harm. It's about hurting themselves. If I ask the person, do you plan to kill yourself? Okay, different question. Okay? So we may have missed it entirely if I ask the person, do you plan to hurt yourself? And the person tells me no, yes. Okay, and then I go into that. But I never asked about suicide. I never asked about life ending. Okay? Does that make sense? Okay. All right. So why does a mental health crisis occur? Not limited to, of course. And again, I'm going to ask for one more word on why it occurs. Right? Bereavement, death of a loved one, non-adherence to meds, prolongs periods of stress, depression, ailing health or chronic illness, divorce, marital conflict, family problems, trauma, past or present, alcohol and or drug abuse. What theme is here? We talked about change being the theme, with signs and symptoms of a mental health crisis and warning signs for suicide. Change. Now, why does that occur? What was the word in the very beginning that I had you all focus on? Loss. That's the reason. Think of it up there. So, loss of a loved one. Okay. Loss of treatment. Loss of control. Loss of health, both depression and ailing health. Loss of marriage. Loss of family. Loss of control again. Okay. And again, loss of sobriety. The revolving theme there is loss, with social and family support. That is really the main primary protective factor, social and family support. With every crisis that we see, we always get collateral information. HIPAA's out the window. In other words, confidentiality is out the window in an emergency situation. If that person's telling me, well, F you, I'm going to sue you if you contact my wife, I don't care. I'm going to contact that family member in order to keep that person safe. Of course, I'm going to also weigh the ulterior motives of the spouse and or other family members, of course, as well. Anyhow, but by getting that collateral information, I access that primary and social support to monitor the person, to supervise the person, but also provide maybe part of the planning, part of the aftercare, things like that. So again, yes, divorced, widowed, and single are the most likely to kill themselves. We talked about age. The more elderly you are, the more you're likely to kill yourself. We talked about ethnicity, Caucasian. Under psychosocial, again, lack of social support. Unemployment. Let's talk about that though. If the person, however, is employed, who is more likely to kill themselves among your professionals? Now, the statistics come from the American Association of Suicidology and the CDC. Don't look up things on the web, by the way, in regards to suicide, because some things will give you some really weird things, okay? But those two sites, American Association of Suicidology and the CDC. Anyhow, among your professionals that kill themselves, who is more likely to kill themselves? Okay, somebody said law enforcement. Law enforcement and military are number 2 because of the trauma, because of the combat, high stress. Somebody said dentist up here, right? I'll talk about dentists here in a minute. What else? What else? A lot of stress, yes, but not necessarily suicide. And I think when we think of professions also, we cannot list every single profession out there in the world. Otherwise, we would have your 7-Eleven clerk, 252nd at risk for suicide. So they listed 5. They listed 5. All right. Attorneys are number 3. Any attorneys in the room? Or spouses? Okay. I usually make a comment there, but I'm not going to make it today. Number 4 is your executive CEOs, or executive businessmen, actually. Okay. And I guess it makes sense. Those are also going to be your impulsive suicides that are rare. Your Enron CEO, where he lost billions. Thousands upon thousands of people were affected by it. The whole country was affected by it. And he jumps out a window. Did he have a history of mental illness? Maybe. Who knows? I don't know. Did he have a history of depression? I know he was definitely under high stress, and he lost everything. At that point in time, he saw no escape. No, he was avoiding what was to come. So again, it was a very impulsive suicide. All right. Number 5, and Mike really hit on it really well, and so did Alfonso in regards to postvention and also when we talk to each other, debriefing, okay, which is going to be key. Think of Fort Hood, Killeen, Texas, a few years ago, or a year and a half, 2 years ago. What profession was that individual that shot up those individuals? He was a psychiatrist and military. So he had 2 professions right there under his belt that are in the top 5. Number 5 is your psychiatrists and social workers. I know. And again, primarily the reason, lack of debriefing. Lack of debriefing. Debriefing can be done in a very informal way. It can be done in a formal way. In my department, and I've said this many times, because it's okay to say this, every single one of my members, 37 people that I have under my department, they've all broken down at some point. I mean, just broken down. And okay, we we have a process where we do a debriefing, either formal or informal. Okay, and all it is really is just talking to another peer. Kind of like in The Sopranos, one psychiatrist talking to another psychiatrist. So again, debriefing is going to be key, truly. Your reactions, how are you going to deal with this moving forward? Are you able to see patients tomorrow? Et cetera, et cetera. All right. So again, just relating to other people is going to be really important. So again, attorneys, CEOs. 5 is social workers and psychiatrists. Number 2, we talked about law enforcement and military. Number 1 is your medical. Dentists are in there too. I don't know why. I don't know really why. A lot of theories out there. I don't know why. But the primary ones, though, under medical, because there's several under number 1, is going to be pediatric oncologist, your general surgeon, your pediatric surgeon. Okay, those are the main ones. So pediatric oncologist, what does he do, or she? Right. So that's going to weigh on the person quite a bit, right? Quite a bit. All right, so those are your professions in regards to suicide risk. Psychiatric illness. 90% of all suicides are completed by a person with mental illness. 90%. That means that 10% were not mentally ill or not diagnosed, one or the other. Don't really know. 90%, though, have either an anxiety disorder diagnosis, okay, a depressive disorder, typically major depressive disorder, or bipolar disorder. Any one of those three. Anxiety disorder, think about it, of course. The person has no end, has really no escape. All right? And again, Mike talked about all that, all those feelings that come into play with an anxiety disorder. And it's also the most common disorder among your mental illnesses in the U.S., the most common, followed by depression. Most people think depression is the most common. Anxiety is actually the most common, okay? That followed by depression. Bipolar disorder, you have one trait, one symptom within this disorder called impulsiveness. You act without thinking. Okay? You act without consequence. All right, so bipolar disorder. Psychological dimensions. These are important. Hopelessness is going to be your number one. Now let's define what hopelessness is. Don't tell me that it's lack of hope. So what's hopelessness? It's a little hard to define.
No way out.
Good, no way out. The way I think of it also is related to the cognitive dimensions, thought constriction and polarized thinking. This is your black and white thinker. Associated typically with an eating disorder, as an example, okay? For instance, if we tell a person with an eating disorder, okay, just eat your dinner. Well, no, I'm going to get fat. Okay, eat half the meal then. No, I'm still going to get fat. Okay, eat a portion of the meal. No, I'm still going to get fat. Eat a carrot off the plate. I'm still going to get fat. Eat half the carrot. I'm still going to get fat. It's constrictive thinking. Polarized thinking. You do something, then there's an effect, period. There's no middle ground. But obviously with everything and anything, there is middle grounds. So hopelessness is lack of future planning. Lack of any type of short-term or long-term goals. Saw somebody a few years ago that had suicidal ideation, so thoughts of suicide. And told me verbally he's going to kill himself. However, he did not have hopelessness. He had a job interview Monday that he was hopeful for. Did we hospitalize the individual or not? Just based on that information. No. Because he's hopeful. We grabbed onto that strength and we capitalized on that strength. Crisis management is not simply focusing on the negative. Crisis management is grabbing something, a strength, and just running with it, capitalizing on that strength. Children in the home is another strength we capitalize a whole lot on. However, not guilt-tripping the person, capitalizing on the strength. Meaning, well, you know your kids are going to miss you if you kill yourself. Is that capitalizing on a strength or a guilt trip? It's a guilt trip. So now you've passed judgment on that person based on their suicidal thoughts. So the person is unlikely now to open up to you in regards to future suicide thoughts. Okay? Rather than saying, it seems like you have a lot to live for. What are your kids' names? Etc. Okay? Psychic pain, fragile thoughts. Okay, obviously we know that sexual physical abuse is a huge predictor for suicide as well. Rape victims, 4 times more likelihood to end by suicide. Family history of suicide, meaning obviously it's not a genetic component, it's a learned behavior. Ernest Hemingway killed himself, father killed himself, grandfather killed himself. His daughter later killed herself as well. So again, family history of suicide, learned behavior. Much like we see 700 people each month, face to face. And many of them are children. Why would a 4-year-old walk into my department saying he or she wants to kill himself? 4-year-old, with limited vocabulary. They had to learn it somewhere. Sure, the person is dealing with a lot of stress, I'm sure, at home, and many, many other factors, maybe family violence, domestic, et cetera, et cetera. But again, it's learned behavior. Prior suicide attempts are also predictors for suicide. How a person has attempted before. Quantity and quality is going to be important. How did the person cut themselves? How many pills did they take? What kind of pills did they take? Etc. Right? Let's move on. I'm running out of time. All right. Okay, this is how we define risk. Based on the psychiatric assessment, we ask specifically clearly and directly regarding suicide. Oh, you all have these slides? Excellent, okay. Risk factors that we talked about. Modifiable risk factors. Can we modify age? Gender? Obviously not. Well, okay, you know what I mean. We can modify hopelessness, though, and instill hope in someone. Okay, so there are modifiable risk factors. Then we take the protective factors and determine ultimately what the level of risk is, low, medium, or high in regards to suicide. Are we 100% sure all the time? Of course not. Let's stop here for a moment. Under the umbrella of lethality, our assessment is called a crisis assessment for lethality. What that means is the person at risk of hurting themselves and or others, period. That's really the criteria and determination on how to hospitalize someone into a psychiatric hospital. So, we look at lethality, objective danger to life, associated with a suicide method or action. Lethality is distinct from and may not always coincide with the individual's expectation of what is medically dangerous. In other words, we're trying to figure out if the person's danger to self and or others, and if there is intent present. Subjective expectation and desire for a self-destructive act to end in death. Much like we talked about, the self-mutilators, there is no intent present. It's still called suicide gesture, though, instead of an attempt. Let's talk about that briefly. Okay, so under the umbrella of lethality, there's a passive death wish. So verbalization. Give me an example of a passive death wish. I hate my life. Okay. I wish I was dead. You guys are just full of passive death wishes. Yeah, I wish I would wake up in the morning, et cetera, okay? They're passive death wishes. Those are warning signs for suicide. Are they saying, oh man, you're gone, you need to go to the hospital? Of course not. But attention needs to be thrown to them. Right? The next thing is going to be suicide ideation. Notice I said ideation, not verbalization. So, what's that? Yeah, you're actually, not planned yet. You're actually now, yes, contemplating suicide. So the thought is going through your mind regarding suicide now in regards to you inflicting, again, self-injurious behavior to end in death. Okay. The next is going to be suicide ideation plus plan. So now you have the idea of suicide, but you actually have an action plan in place. You have maybe perhaps rehearsed it. You have method, time, and place set in place, or put in place. I'm going to hang myself off the garage with a rope that I have on the anniversary of my mother's death tomorrow. Okay? So now you have actually put method, time, place, means, and access. Maybe even arrange the sequence of events. Now, again, when somebody does something impulsive, obviously none of this is in place. But impulsive suicides are actually rare. These are much more common, where the person actually puts everything in place. All right. Now, the next, we talked about passive death wishes, suicide ideation plus plan. Then we have suicide gesture. And most people ask, well, why is suicide gesture under lethality when the person doesn't really intend to kill themselves? Suicide gesture is self-mutilating acts. Again, the cutting. Most common place to cut, forearms, followed by thighs, and then stomach, and then neck. Typically by your adolescent population, typically female, again, to relieve anxiety, psychic pain, et cetera, et cetera. But it's under the umbrella of lethality because a lot of times they cut too deeply. They need to feel that same adrenaline rush that they did the first time, chasing the dragon. Okay? So hence, the person's going to cut too deeply and then end life, known as accidental suicide. Okay? Some people believe that Heath Ledger was not a completed suicide. It was an accidental suicide. I don't know. Okay? Finally, I'm sorry, we have suicide attempt next. Suicide attempt is an actual act to, again, end in life. Either an overdose, cutting, firearm, etc., etc. And finally, completed suicide. I only have about 7 minutes, running out of time. So, y'all tell me questions in regards to crisis management, suicide intervention. We talked about risk factors, protective factors, warning signs, what to do. Again, the best thing you can do is listen, act. Act by asking. And really handing off the person to someone else that may be more of an expert, obviously, in regards to what's going on with them, whether it's a counselor, a crisis center, whatever it is. So, questions in regards to the service as well? Yes.
If the person is not verbalizing their intentions and you're reading their body language, how do you get them to see themselves? At that point, do you actually make the call, or?
Okay, so you're asking the person if they're suicidal and they're saying no,
Right,
and you're thinking otherwise.
right.
Okay, so you're asking, how do you try to convey, in other words, for them to tell the truth?
I'm trying to get them out.
Okay.
I want them to go, and I want them to not complete this act.
The best thing to do in those type of situations, if you believe, again, the person is lying to you in regards to suicide or whatever it might be, is to first off build further rapport. If you're asking a question and they're not answering it, they're either being vague, evasive, whatever it is, or they're simply not talking to you, I like to give them some space. I like to give them time. I like to step away for a few minutes and just come back. And then at that point in time, hey, you ready to talk to me now? But not be confrontational either. Building rapport and actually introducing why you're there and the purpose behind you being there. We actually even instruct our billing clerks, because everybody comes into the department, also gets a financial. Okay? Crises, no, but everybody gets a financial nonetheless. But the billing clerks are there to also indicate why they are there. My name is Martha. I'm here to do your financial. Rather than saying, let me get your information. Well, who are you? Why are you doing this? It's a matter of introducing yourself, why you're there, reassuring the person the purpose. I'm here to help you. Okay? I'm here to listen. Now, one question I pose with this question that you asked is, do we push a person to open up when they don't want to open up? Mental health first aid teaches us no. That we should not push the person to open up if they do not want to open up right then and there. What do? We let them know that we're going to be there for them, though, and what's available to them. Now, if imminent risk is present, different story. If you believe imminent risk is present and the person's still telling you no, body language is telling you something different, then you proceed with something else. You proceed with a protective order or whatever it might be then at that point in time. If you have all these other factors in place, you have a suicide note, you have a family member telling you he's going to kill himself, he's going to do this, he's going to do that. The person's telling you, no, I'm not going to kill myself, I'm fine. Well, then at that point in time, you act. Okay? You act. So again, that's why I say every individual is going to require an individualized, tailored action based on the person and how they're reacting. Other questions? So that's why I took so long for that.
Can you touch real quickly on the emergency detentions? Because a lot of times when you're in the field, you're not real clear about emergency detentions. When you're in an inpatient setting, it's pretty clear. But when you're in outpatient setting, can you just
Sure.
kind of touch on that?
And you can definitely have an extra 5 minutes, so don't worry about going over the time.
Okay, thanks. An emergency detention is also known as a protective custody order by police officers, many, right? PCO? Yeah, okay. We have an officer back here, so that's why I know him. An emergency detention can be done by anybody. I can do an emergency detention on Alfonso right now, okay? If I believe that he's a danger to self and or others for whatever reason it might be, then I'm going to do that. I apply The paper, the form itself, is either at 1600 Montana with El Paso MHMR, or at the county attorney's office, or any officer will also will be carrying those. You can call 911 and get that order as well in place when the officer arrives. So there's many avenues to get that. And really truly what that is yes, it's going to require an officer picking up the person. However, it's going to be a peace officer. It's going to be hopefully somebody trained already in mental health first aid, that we've already trained all the officers and what have you in crisis management and things like that. That's going to obviously be a little bit more gentle with the person. Yes, the person will be coming in handcuffs and things like that. Okay, that's how it is. And either taking to 1600 Montana to our department or to an emergency room to be, again, receiving a psychiatric assessment. So hence a risk assessment. Based on that risk assessment, then the person is considered low, medium, high for danger, and at that point in time, disposition is made. So psychiatric hospital, not psychiatric hospital, aftercare, outpatient services, whatever's necessary. Sometimes a person refuses entirely. Sometimes a person is not a danger to self others. What do? Then you abide to their rights. If they don't want anything, they don't want anything. And if they're not a danger to self and others, we cannot force that onto them. That's one of our biggest hurdles, is having family members come to us and saying, look, this person is this way, that way. After multiple assessments have been done, even by an MD, no danger to self has been established. But yet the family member is saying that they're danger to self and or others. So again, it's a hindrance at times.
I was just wondering, as we're talking more about the PCOs, if there's been any research on how effective they are. Because I imagine that when working with this population, we often hear the fine line between crazy and brilliance. And I find that that's true.
Mm-hmm.
And so how long is before they get PCO one or two times, and then they figure out, well, I'm not going to act out. I'm just going to go and do what I want, rather than weighing the symptoms.
Right. Typically, a PCO truly is done when the person is really decompensated a lot of times. Is it associated with suicide? Yes, because decompensation due to mental illness is another reason to PCO or ED someone. No, I don't know of any research that has been done, honestly. But I'm sure it can be very stigmatizing for the person to be picked up by a police officer and taken there. And then it's a revolving door over and over again. And finally, the person, if they're coherent enough and they have enough insight and judgment, are they going to subside those symptoms? Sure. But if they're truly mentally ill, they probably can't control those symptoms. So, yeah. Other questions? Other risk factors that we have missed: marital status, age, gender, occupation, where you live. Substance use, absolutely. Okay. We talked about it very briefly, but that's a whole half a day in regards to crisis management and substance abuse. Those that are under the influence are going to be much more likely to complete suicide. Again, loss of inhibitions, right? Impulsiveness increases. Yes, ma'am.
Follow-up with the MHMR class in regards to family support once you've had somebody, a family member taking client, well, not necessarily a client, but if a family member wants a risk assessment to be done on this person, and like you said, numerous risk assessments have been done, and it demonstrates that the person is not in danger, we do understand that the client or the patient at the time will have to do a lot of manipulation for this to happen. And then later on, if the family doesn't have the resources or the support to provide for that individual, it's find out that the person committed suicide.
Mm-hmm. Good question. Here's what you do then. If the person has multiple times failed to, because remember, there's a fine line between non-adhering to medications and treatment and then becoming danger to self others. There's that fine line. And a lot of the times, a person can be very, very forthcoming and very, clear-minded when they're being assessed. I've assessed a VA vet many years ago, 65-year-old Caucasian male, and he's coherent, no psychiatric history. And he got EDO'd, in other words, emergency detention. We asked him a Del Sol, and he got EDO'd by his spouse because he grabbed a gun, pointed at his chest, and said, I'm going to kill myself. Okay, that's all I got. So I go and assess him, And he tells me a completely different story. And he's coherent, lucid, he's oriented, all spheres. Again, no psychiatric history. That's what throws me off completely, of course. But he is a veteran. He is Caucasian. He's male. Okay? So some risk factors. There is a gun in the home, another risk factor. There's obviously marital conflict, another risk factor. There's medical issues, another risk factor. But he is so coherent and just telling me everything, anything that I want to hear. Okay? I call the spouse. The spouse changes her story a little bit now. So I'm like, so I'm trying to weigh, are they just simply fighting? And she did this protective order on him to get him out of the house, to get him, who knows? So I'm trying to figure it out. And I don't want to violate his rights by putting him in this restrictive environment when he doesn't need to. And when research shows if we hospitalize people in psychiatric hospital that don't need to be hospitalized, it's actually counterproductive. So, bottom line is, I couldn't figure it out. I hospitalized him. Okay? Because that's the best route I could take. Of course, we have a psychiatrist on call that obviously we consult with, so that's what helped out as well. Anyhow, so really the best answer for you is doing perhaps a court-ordered outpatient commitment. Court-ordered outpatient commitment. What that means is if a person who is mentally ill is not complying with treatment on an outpatient basis, they're not quite up to the criteria for psych inpatient, then you do, same thing, county attorney's office, et cetera, you see what's called, an court-ordered outpatient commitment. So if the person does not comply with outpatient services, they go into the hospital. Okay, make sense? Okay. However, again, you have to prove that the person is truly not complying with treatment on the outpatient side and is not complying with treatment, and because of that, he is decompensating slowly. Because again, we cannot force a person to be treated psychiatrically when they don't want to. I mean, you see them downtown, right? Just singing and dancing and everything else and talking to themselves. They're not a danger to self others. They're delusional. They're delusional. Now, when those delusions become shadows that are attacking them and they're attacking people in the plaza, okay, different story. Because there is a misconception out there, oh, the person's delusional. They're hallucinating. They have to be danger to self others. Absolutely not. No. They're just experiencing psychiatric symptoms that need to be treated. They're obviously being untreated for whatever reason. But obviously our role is to try to convince the person to get those necessary treatments. So, okay. Yes, ma'am.
In terms of preteens or teens, is there certain behavior that's more prevalent? I mean, I see some of these, but I'm just thinking of experiences or instances that I know of. Is there something that is more prevalent that you find, perhaps maybe sexual orientation, or I don't know, I'm asking, is there something more prevalent?
I'm not seeing it. We are now, for the first time ever, actually outreaching to the LGBTQ community. We have never done that before in the past. We have not seen a rise in adolescent suicides for any specific population within the adolescents. Nationwide, however, African American females are rising in suicide among that age group for the first time ever in history. So.
I work in the home health setting as an occupational therapist and social work. And a lot of times we have to refer to APS for noncompliance issues. And they send out a psychiatrist, but only on those patients that they deem are not competent. Do you ever foresee in the future a collaboration with APS on doing any form of counseling on patients that are not appropriate for psychiatrists, that are appropriate to deal with other mental health issues?
Okay. Counseling to address.
Related to compliance.
Okay.
Related to, not caring for self, living in situations where they're not appropriate. The home's cluttered and, I had a patient that never left the house. And when we went to see her, she had people bring her clothes into the house because she didn't want to wash the clothes.
I attend a hoarding coalition, actually, hoarding committee or something like that. Anyway, and believe it or not, actually El Paso is one of 4 in the nation that has a hoarding coalition. and it's a fairly big problem. Obviously, as you know, hoarding is an OCD behavior. It's all anxiety. However, there's one case, for instance, that we discussed yesterday that is not related to anxiety. It's all related to medical, where he's in a wheelchair and he cannot basically care of his, his environment. So he's hoarding and hoarding and hoarding trash and hoarding other things, where it's becoming close to danger to self at that point in time. But he does not want to move. He does not want any of this. He is within his own right mind, as determined by already a doctor. He's simply refusing. So what do you do at this point in time? Do you wait until the place blows up a little bit and then take him? Sure. Or do you wait until maybe he's medically unstable, and at that point in time, direct him to a nursing home? And that's kind of what the decision was made. But there's avenues to take in these type of cases. We actually do a lot of outreach with APS already. And what do you, right?
Right, we do a lot of collaboration because, again, we share some of the same population. But again, as Jesus mentioned, we've got a lot of our clients that do ward as well. We had one individual that literally, on trash days, he lived with his mother. His mother was in her 80s. He was probably in his late 50s. And he would collect trash, just random trash. In other words, people would have empty trash cans before the trucks would come from. And he literally filled up the boards of the entire house. And so in addition like that, it is other conditions of schizophrenia. But if that was only the primary diagnosis, then again, because of Texas, we have the priority populations against schizophrenia, major depression, and bipolar disorder. Then it becomes a little bit more difficult. Doesn't mean we're gonna, shut our doors and not be willing to discuss, because we do try and collaborate as much as possible. And our crisis intake unit, of course, is open to anyone, regardless of whether they have a diagnosis or not during a true crisis. So we try and collaborate as much as possible. But because of funding and resources, sometimes those are things. There's so much more that we wish we could do. And again, on the preventative side, on the outpatient side, that would solve a lot of issues and prevent a lot of emergency room visits and things of that nature.
I'm going to discuss just two things before I end. One is going to be suicide for secondary gain. The reason I'm discussing is because so we can understand truly the dynamics and how multifactorial truly suicide is. Will you all see this in the community? Necessarily not really. We see it, of course, pretty continually, and it's our job to determine, is this person a risk to themselves or others, or is there suicide for secondary gain? Okay? Suicide for secondary gain is, if you leave me, I'm going to kill myself. Or police officer arrives to a domestic violence scene after husband beat up wife. The husband says, oh, I have a history of depression. I'm suicidal. What is he trying to avoid? Incarceration, precisely. Okay. Now, could his behavior be a result of his mental illness? Possibly. We will determine that. But a lot of the times, it may not. Okay. So again, suicide for secondary gain is a real thing. Okay. It is a real thing. Will you see it? Not really. Last thing, reporting by media. Suicide should not be reported by media, although, and we're already doing outreach with the media on how to report media. I was like, yeah. A few months ago, Channel 9 reported a man that was on the top of a building on the east side somewhere. And it was I think it was at 5 o'clock, and essentially they had a reporter there live, or somewhat live, reporting and talking to the individual, and it's like, oh my God, really? Are you really doing this right now? And why would you be broadcasting that over the, the television? So bottom line is the individual was upset because Obama had just flown out, and he wanted to speak to Obama directly, but was not gained access. So hence he was suicidal. So he climbed top of a building, fairly tall building, and he wanted to jump off. So a reporter was trying to de-escalate him, not very well. Finally did the right thing and actually got another reporter next to him to say, hey, why don't you call 911? And that's what they did, of course. We got a hold of it and said to our chief external affairs officer, in other words, our media relations person, we really need to outreach the media on how to report correctly. This community is not too bad, though. I've seen other communities where they sensationalize suicide in a huge way. What that causes is many, many things. It causes suicide contingent, and it causes suicide clusters. Suicide cluster is a 15, 16-year-old complete suicide at some high school. Then suddenly 3, 4 complete suicide thereafter because the person related to that individual in regards to her characteristics, to her problems, her stress, etc., etc. Suicide contagion is one person completes suicide that they hear over the television or what have you, then the person says, well, yeah, that's a great way out. Maybe I will do that as well, etc., etc. So again, media does have a responsibility on how to report suicide. Yes, if it disrupts traffic on Spaghetti Bowl and things like that, I guess I can see that, but again, it's about responsible reporting. That's all I have. If you all have any questions, feel free to come up here. I know we're way out of time. Thank you.